Hi everyone, my name is Mohammed Zubair. I'm a resident in nuclear medicine, and in my daily practice I encounter many patients with thyroid-related diseases. Because of this, I created a series of videos in which I explain everything related to the thyroid gland, from its normal physiology to different pathologies and important diagnostic tools. You can watch the entire series in order, or simply go to the playlist and choose the videos that interest you most. This video is the last part of a 4-video educational series about the thyroid gland. In this video, I will explain the thyroid scan and the use of radioactive iodine. A thyroid scan is a nuclear medicine examination that uses a radioactive tracer along with a special camera to measure how much of that tracer is absorbed by the thyroid gland from the bloodstream. This can help determine the size, shape, and position of the thyroid gland and can also identify areas that are overactive or underactive. The thyroid scan consists of 3 main phases: administration of the tracer, image acquisition, interpretation of the images. The time between tracer administration and imaging can vary from a few minutes to several days, depending on the type of tracer used. The tracer used is either technetium or radioactive iodine. Technetium is more commonly used due to its availability and lower cost. Patients may either swallow radioactive iodine about 24 hours before the scan or receive technetium through a vein 20 to 30 minutes before imaging. This waiting period allows the tracer to be absorbed by the thyroid gland and emit radiation, which is then detected by the camera. During the scan, the patient lies on a bed while the camera is positioned close to the neck area. The total scan time is usually 10 to 15 minutes. Tracer uptake reflects thyroid activity, as the radioactive tracer behaves similarly to normal iodine uptake. Uptake is typically low or absent in thyroiditis. Autonomously functioning nodules appear as localized areas of increased uptake, while Graves' disease shows diffuse and symmetrical uptake across both thyroid lobes. It is important to note that radioactive iodine exists in 2 forms. Iodine-123 is harmless to thyroid cells and is used for diagnostic imaging. Iodine-131 destroys thyroid tissue and is therefore used in the treatment of thyroid cancer and Graves' disease. In summary, technetium and iodine-123 are diagnostic tracers, while iodine-131 is a therapeutic radioactive drug. Iodine-131 delivers a higher radiation dose and is most effective when blood levels of TSH are high, which increases iodine uptake by thyroid cells. TSH levels can be increased in 2 ways. The first method is stopping thyroid hormone medication levothyroxine for 3 to 6 weeks, which naturally raises TSH levels but may cause symptoms of hypothyroidism such as fatigue and cold intolerance. To reduce these symptoms, short-acting T3 liothyronine may be prescribed temporarily. The second method is administering synthetic TSH injections, allowing the patient to continue thyroid hormone therapy while still achieving adequate TSH stimulation. Although treatment with iodine-131 is considered safe, patients must minimize radiation exposure to others, especially pregnant women and young children. Depending on the dose, temporary isolation in the hospital for 2 to 4 days may be required. Patients treated for an overactive thyroid usually experience minimal side effects due to the low dose. However, patients treated after thyroid removal for cancer may experience side effects such as dry mouth or salivary gland discomfort. The effects of radioactive iodine therapy typically begin within 1 to 3 months, with maximum benefit seen after 3 to 6 months. In most cases, a single dose is sufficient to treat hyperthyroidism, often resulting in hypothyroidism, which is managed with lifelong thyroid hormone replacement.